So let's take a deep dive into the etiology of hypertensive disorders in pregnancy, because it is the etiology which you need to know in order to understand the wide clinical spectrum this disease has. So hypertensive disorders during pregnancy, they are more likely to develop in women who either are exposed to chorionic villi for the first time. That is why I told you that primiparous patients or patients who have never conceived but are conceiving with ART procedures like IVF, ICSI, these are at high risk of developing HDPs. Second, if they are exposed to a superabundance of chorionic villi, because ultimately the pathology is uteroplacental. Okay, so those with a high abundance of chorionic villi, like a multiple pregnancy or an Rh negative pregnancy for that matter, anemic pregnancies in which the placentas tend to be larger, or have pre-existing vascular disease, again a diabetes mellitus with vasculopathy or hereditary thrombophilias, they have a higher risk of preeclampsia and attendant complications. And lastly, who are genetically predisposed. So, uh, you know, first degree concordance and sibling concordance, these are higher in cases with preeclampsia. So, these are the women who have a greater chance of HDPs, and we need to understand why this happens, and this can be explained well by the two-stage disorder hypothesis. Okay, so what is the two-stage disorder hypothesis? Basically, we have an abnormal trophoblastic invasion of the spiral arteries. So what happens in pregnancy? Ideally, these spiral arteries are perfusing the placenta. Now, this trophoblast from the placenta is going to invade the muscular wall of these spiral arteries, and it will transform them into maternal sinusoids. So, when these spiral arteries get transformed into sinusoids, there is a change from the high resistance, low flow system of spiral arteries, high resistance, low flow system as it previously used to be. Then there is trophoblastic invasion, which converts this into a low resistance, high flow system. This is what happens in a normal pregnancy. But when there is an abnormal trophoblastic invasion, there is an inappropriate endothelial cell activation, there is exaggerated inflammatory response, and these all are the key features in the pathogenesis of preeclampsia. So this conversion of spiral arteries from a high resistance low flow system into sinusoids of low resistance high flow does not take place in preeclampsia. So what is the primary stage in this two-stage disorder hypothesis? It's the abnormal placentation. So this is again a reiteration of the fact that in normal pregnancy, the wall of the spiral arterioles is invaded by the endovascular trophoblastic cells. This migration transforms the small musculoelastic spiral arteries into large and tortuous channels that carry a large amount of blood to the intervillous space. And this is a very important fact that these are resistant to the effect of vasomotor agents. So whatever endogenous or exogenous vasomotor agents or vasoconstrictive agents are there, because these spiral arterioles have been transformed into sinusoids, which basically lack a tunica media where these vasomotor agents act, that is why they are refractory to the action of these vasoconstrictive agents. Now, these physiologic changes are incomplete in patients with preeclampsia, and the trophoblastic invasion affects only some of the spiral arteries and does not progress into the myometrial portion of the arteries. That is why there is an increased risk of these arteries being responsive to vasomotor agents, and they are not the low resistance high flow channels which we want for adequate fetal perfusion. So this deficiency of trophoblasts to invade into the tunica media of these spiral arterioles all over the placenta results in uteroplacental perfusion defect. Okay, so this was the first stage, the abnormal placentation. Now what is the second stage? The second stage of this two-stage disorder hypothesis involves the conversion of the earlier described uteroplacental maladaptation to the maternal systemic syndrome of preeclampsia. I told you preeclampsia is a widespread disease. It is not only the fetus which is affected, not only the placenta which is affected, but instead all the systems of the mother are affected as well. So the secondary stage of systemic maternal disease, it is associated with an exaggerated endothelial cell activation and a generalized hyperinflammatory state. So the anatomic and physiologic disruption of normal placentation is thought to lead to release of placental debris from the intravenous space into the maternal circulation. So what happens when there is abnormal trophoblastic invasion? It's not going into the spiral arterioles. It leaks placental debris from the intravenous space into the maternal circulation. Now this placental debris, which is there in the maternal circulation, this placental debris incites a systemic inflammatory response. So it incites a systemic inflammatory response by stimulating the synthesis of either inflammatory cytokines or products that affect angiogenesis, and they cause abnormal lipid peroxidation as well. So that is how a disease which was prior localized only to the placenta and the fetus now becomes a part of a larger picture of a maternal systemic syndrome. And we know that these inflammatory cytokines, the tumor necrosis factor, these anti-angiogenic factors, they will affect the endothelial system of each and every organ in the mother, that results in the typical signs and symptoms of multiple organ compromise in preeclampsia. So you understood the two-stage hypothesis? I'll go through it again quickly. Just a sec. Yeah. So in two-stage hypothesis, there is an abnormal trophoblastic invasion of the spiral arteries. This is the first stage. Second stage is the endothelial cell activation, the exaggerated inflammatory response leading to the maternal systemic syndrome. In the abnormal presentation, the spiral arteries are not converted into low flow channels or sinusoids and remain responsive to vasomotor agents. That results in uteroplacental perfusion defect. In the systemic syndrome, there is a risk of exaggerated endothelial cell activation at generalized hyperinflammatory state, which is responsible for the multiple organ compromise in preeclampsia. So this is just a pictorial representation of the same. In pregnant women, normal pregnancy, the trophoblast is just reaching up right up to the base of the spiral arterioles, eating up the tunica media and converting it into a sinusoid, which is responsible for good perfusion. Whereas in preeclampsia, this trophoblastic invasion is incomplete and inadequate, resulting in uteroplacental perfusion defect. So, after reading about this endothelial cell activation, the hyperinflammatory state, there's something which strikes a balance between the angiogenic factors and the anti-angiogenic factors. So, the concept of angiogenic imbalance is relatively new in preeclampsia, and it describes that there is a production of excessive amount of the anti-angiogenic factors by the trophoblastic tissue, which is stimulated by worsening hypoxia and uteroplacental interface in patients destined for preeclampsia. So there are certain pro-angiogenic factors which help in vascular growth and neovascularization, development of healthy placental channels, but there are certain anti-angiogenic factors at the same time which hamper this process. So what are these anti-angiogenic factors? Soluble FMS-like tyrosine kinase 1, which is abbreviated as SFLT1. It is a protein produced by the placenta. And how does it act as an anti-angiogenic factor? It acts by binding to the receptor binding domains of the vascular endothelial growth factor and the placental-like growth factor. So, this PLGF and the VEGF, the placental-like growth factor and the vascular endothelial growth factor, these are both angiogenic. Okay. And these are counteracted by the anti-angiogenic factor SFLT1. And this imbalance in favor of SFLT1 is responsible for development of preeclampsia. So the increased maternal levels of SFLT1 inactivate and decrease circulating levels of free PLGF and VEGF concentration, resulting in endothelial cell dysfunction. And of course, the magnitude of increase in FSFLT1 levels correlates with the disease severity. So here comes the teeter-totter theory or the seesaw theory of preeclampsia, development of preeclampsia. So we know that the seesaw is in favor of the anti-angiogenic factors like SFLT1 and soluble endocrine, and there is a decrease in the pro-angiogenic factors like VEGF, placental-like growth factor, nitric oxide, and that is why this results in a lot of uteroplacental perfusion defect, ultimately affecting the baby and resulting in early onset fetal growth restriction. So this is the teeter-totter theory. I somehow mentioned the name of Chesley, and Leon Chesley is a stalwart in understanding preeclampsia. He's written books over preeclampsia, and he calls preeclampsia as a disease of theories, right? So these are the two theories which we just read: the two-stage disorder hypothesis and the concept of angiogenic imbalance. Now, what all changes happen with preeclampsia in each and every organ of the body? So, in the uteroplacental bed itself, there is a syncytial degeneration and there are signs of premature aging of the placenta. Okay, so both of these contribute to uteroplacental insufficiency. If we talk about the liver, there is a periportal hemorrhagic necrosis. We know that according to the lobular and the zonular classification, we have a centrizonal necrosis and we have a periportal necrosis in the liver. So, like this. So, they are hexagonal cells. Okay, hepatocytes are hexagonal cells and they are like this. Okay, so it's it's a central vessel, and here about is the zone which is responsible for different sorts of metabolic activities. And if this is affected, this is called as centrilobular necrosis. And at the junction of these hepatocytes, somewhere here are the portal triads. And if any pathology affects this area, it is called as a periportal pathology. And this is the area where preeclampsia tends to affect the liver, resulting in a periportal hemorrhagic necrosis, and rarely it might also result in a subcapsular hepatoma. So there's the liver, there's the Glissen's capsule over it, there's collection of the blood, there's an impending hepatic rupture and leaking of the blood beneath the Glissen's capsule, which results in stretching of the Glissen's capsule, and that results in the right upper quadrant pain if it is in the right lobe of liver, or the epigastric pain if it is in the left lobe of liver. And that is why we need to keep a high suspicion on the subcapsular hematoma, because this can endanger the life of the woman as well. So after discussing about the uteroplacental bed and the liver, next comes the kidneys. So what is the classic or the hallmark lesion of preeclampsia? As far as the kidneys are concerned, it is glomerular endotheliosis. So basically, it's like an MPGN or a membranoproliferative glomerulonephritis, where this soluble substance, hyaline substance, is deposited into the capillaries, thereby affecting the renal filtration and resulting in increased serum creat levels and decreased GFR in pregnancy. This is what is the hallmark lesion. Rarely, bilateral renal cortical necrosis can happen, which tends to be irreversible. Okay, so if there is an ATN or an acute tubular necrosis, it can be reversed to an extent, but the cortical necrosis is mostly irreversible, and it's a dreaded complication of preeclampsia. Now, in the brain, there's something called as a PRES, that is posterior reversible encephalopathy syndrome. I'll be discussing about it in detail later. Heart, you can have subendocardial and subendothelial hemorrhages, and acute respiratory distress syndrome in lungs, hemorrhagic gastritis in the stomach, hemorrhage like the Waterhouse-Friderichsen syndrome in the adrenals. Then if the water and electrolyte imbalance is talked of, the net effect is of an intravascular dehydration and an extravascular overhydration. So it's just like starvation in the midst of plenty. So there is a lot of fluid, but it is not in the intravascular compartment. Instead, it has leaked into the third spaces, and there is an extravascular overhydration and an intravascular dehydration. And lastly, the hematological changes. So there is a rising hematocrit, so a hemoconcentration for sure, a falling platelet count, thrombocytopenia, and even disseminated intravascular coagulation in severe cases of preeclampsia. So after understanding the pathophysiology of preeclampsia, we come to the pathophysiology of eclampsia. So we know that it is still not conclusively elucidated, but we have different speculations regarding the pathophysiology of eclampsia. Autopsy studies have shown that there is cerebral edema, there are cortical and subcortical white matter microinfarcts, and pericapillary and parenchymal bleeding predominantly in the occipital and the watershed areas. So occipital lobes, you understand, it is more so in the back of the brain where this pathophysiology lies. This is the reason why it is associated with visual disturbances, scotomata, etc. And what are the watershed areas? We know that the brain is supplied by the anterior cerebral, the middle cerebral, and the posterior cerebral arteries. And it is like that the anterior cerebral supplies some part, then there is middle cerebral. So at a junction of these two, when the anterior cerebral circulation ends and the middle cerebral circulation begins, or even when the middle cerebral circulation ends and the posterior cerebral circulation begins, these are the watershed areas which are basically not being supplied by any of the major arteries, and they are at a risk of being insulted, or they might suffer a vascular insult during an eclamptic seizure, right? So that is why watershed areas are the most prone for damage in eclampsia. So what is a likely explanation for the occipital lobes to be affected more? So it is said that there is posterior predominance of brain lesions in eclampsia. It is a well-known fact. Why is it so? Because the anterior circulation of the brain is much better supplied with sympathetic innervations, and therefore it is better protected against the effects of elevated blood pressure rather than the posterior part of the brain. So we know that the cerebral system has its own auto-regulatory mechanism as far as the hemodynamics is concerned, right? So this auto-regulatory response is more so in the anterior circulation because it has a lot of sympathetic innervation, and it is able to adjust itself, adapt itself to the different pressures the brain is facing. But the posterior circulation is not that adaptive. It is not able to adjust to the rising blood pressure, and therefore the occipital lobes are at a higher risk of damage as compared to the frontal or parietal lobes. Okay. This was about the pathophysiology. Now, we also know that the MRI findings in eclampsia are similar to those found in non-pregnant patients with hypertensive encephalopathy. So, we know that this pathology is similar to that of hypertensive encephalopathy. In eclampsia cases, vasogenic edema is the result of forced leakage of serum through the capillary walls, because the capillary walls are more permeable, fluid leaks out based on Starling forces, and there is a vasogenic edema due to increased perfusion pressure that is mainly a result of the systemic arterial pressure. Okay. Now, an explanation for the onset of seizures. Now, all this has happened. So there is a cerebral edema, there are microinfarcts, there is an insult to the occipital lobe. But why seizures? So the onset of seizures can be explained by the fact that seizures are the result of an abnormal autoregulatory response, which consists of exaggerated vasoconstriction and ischemic changes, with rupture of the vascular endothelium resulting in pericapillary hemorrhages, development of foci of abnormal electrical discharges. So there are short electrical loops which are running in these areas which are afflicted by the pathology of eclampsia, that generalize over time, and they result in convulsions which are classically of the GTCS type or the grand mal type, that is the generalized tonic-clonic seizures of eclampsia. So I told you I'll talk about PRES, and yes, I'll fulfill my promise of talking about PRES. So PRES is posterior reversible encephalopathy syndrome, and by posterior I mean it affects the occipital lobe and the posterior parietal lobes. Now, how do we define PRES? It is just a transient neuroradiological entity that is characterized by features of hypertension, generalized seizures, and altered mental status, headache, persistent headache, and even vision changes. So, if any of these are found and there is also a radiological evidence of the same, you may say that the woman is suffering from posterior reversible encephalopathy syndrome. What is the hallmark of diagnosis of PRES? So you have bilateral symmetrical vasogenic edema in the occipital and posterior parietal lobes. I'll show you a picture of it as well. And it is mostly evident in the T2 weighted MRI images, right? Underlying pathology is thought to be cerebral edema and even vasospasm of the cerebral and retinal vessels. So there is a neuroradiological entity, but there is hypertension, there is seizure, there is an altered mental state, there is persistent headache, there are visual changes. On T2 weighted MRI, you're able to see bilateral symmetrical vasogenic edema in the occipital and the posterior parietal lobes, and the underlying pathology is cerebral edema along with vasospasm of cerebral as well as retinal vessels. Now, the name suggests that it's a reversible syndrome, right? So, PRES is usually reversible with prompt diagnosis and treatment. Rarely it may lead to cortical infarction and irreversible ischemic damage and even death. So you do not take PRES lightly, okay? Because in rare circumstances, it can go to a state where it is irreversible and may even cause death of the woman suffering from it. Now, when do we need to do radiological imaging? So, neuroradiologic imaging should be done in a patient who's complaining of persistent headache or persistent hypertension, recurrent seizures or visual changes even in the postpartum period. So, despite all your measures, if she's complaining of these persistent symptoms, it is better to take her up for an NCCT or an MRI. The classical radiologic appearance of PRES, vasogenic edema in the subcortical white matter in the two posterior cerebral hemispheres. This is basically affecting the occipital lobes and may even extend to the posterior parietals as well.